your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome to Dr. Gore's show. It's my pleasure to have my dear friend Dr. Hetal today, and we're going to talk about postpartum depression. Commonly seen but not too much heard about, and it's something that women sometimes don't come up and talk about it. So we want to bring this topic out in open, and to talk about that, Dr. Preetesh Shah is with us. Dr. Shah did his medical school training in Ahmedabad in India. Then he came to New Jersey, did his training in psychiatry at Bergen Regional, and he went on to do a fellowship in forensic psychiatry at NYU. He stayed there as a faculty in Elmhurst, and he's now in private practice for the last 15 years. So welcome to Dr. Gore's show.
Thank you, Dr. Gore.
And we're going to talk about postpartum depression. As you and I were talking, we see it in the, our practices, but we don't often talk about it because sometimes there's a stigma. People don't want to talk about their emotional needs. But what's the prevalence of postpartum depression?
So postpartum depression is, as you rightfully pointed out, fairly unrecognized kind of a syndrome. And the prevalence is very high amongst women who are of childbearing age who have just given birth. So if you look at the general statistics, then following birth, women frequently go through what are called as postpartum blues.
Correct.
And the incidence of that might be as high as 40%.
Right, because there's so much changes happening in their bodies, the hormones. Then the baby's not sleeping, getting up and affecting the sleep cycle. So there's lots happening. But that's normal. That's the postpartum blues.
Well, again, those depressive symptoms, which are milder depressive symptoms, tend to usually go away within the first couple of weeks after delivery. As you rightfully pointed out, the hormonal status might normalize, the mother might then start getting into a good routine, the child is now, at home, and, there's a little bit more confidence in taking care of the child, there's a social support there. So there are a lot of factors that come into play that might help the mother. But then about 10% of people might experience what is commonly referred to as postpartum depression.
Correct.
Now, this is a more serious issue.
Right.
Because this then requires and demands treatment and intervention.
Correct.
Because if left untreated, it could potentially become quite disruptive for the mother, the family, the child, and as such, may not necessarily just go away without treatment.
So is there a risk factor, like is somebody more prone to postpartum depression than others?
Absolutely. Some of the more common risk factors might be a previous history of, say, depression or a previous history of psychiatric disorders, which might be something like anxiety disorders, bipolar disorder, sometimes even psychotic disorders like schizophrenia, things like that. So those are some of the risk factors.
Right.
But the bigger risk factor that we have to always sort of take into consideration is when people are, when the young mother or mother-to-be is pregnant, and then before delivery starts experiencing these symptoms of depression.
Correct.
Then we have to be more concerned about postpartum depression.
Right. So, and as we as an OBGYN are required now to do is during the course of pregnancy, we have to do this questionnaire that if they've experienced any anxiety before pregnancy, depression, because that personal history and stressful condition, so we have to look for any stress in the work, family, so major death, major events, something like that, or bad experiences during pregnancy. Those are kind of red flags that we have to keep an eye.
Absolutely. Stressful situations, whether they are social stresses, as in family issues or work-related issues or things like that, can very commonly lead to a relapse of a pre-existing condition, and as such, then snowball into a significant depressive cycle, which may require even treatment before the
delivery takes place.
The mother to be delivers, and therefore we have to sometimes intervene even with medications or other treatment options
during pregnancy before the baby is born.
Absolutely.
Right. Now, once we've identified this patients who are at a little bit high risk, also somebody who has bad obstetric conditions, sometimes I find that when they have a difficult pregnancy, difficult labor, they tend to sometimes, exaggerate their underlying, depressive or anxiety, or even like bipolar conditions. Apart from giving them a good social and, support,
yes,
we do send it to a psychiatric or psychological evaluation. When you see these people, what is the initial line of management? You definitely talking to them and getting a good history.
So the first thing one has to do is to make an accurate diagnosis.
Correct.
And when we talk about postpartum depression, then we have to look at certain basic criteria. There are two cardinal criteria that one has to meet first before we move forward. The first cardinal criteria is a sense of depression, sadness, despondency for at least 2 weeks or more,
Right.
where the person is depressed for most of the day.
Right.
Then comes the second cardinal criteria, and that is lack of pleasurable activity, where the
Right.
person does not enjoy doing anything. And following that, if they meet those two cardinal criteria, then we look at other depressive symptoms, such as difficulty with sleeping, difficulty with concentration, forgetfulness, guilt feelings, worthlessness, helplessness, hopelessness, sometimes even suicidal ideas,
Correct.
or even in severe cases, even homicidal ideas towards the baby or others. So those are some of the symptoms of depression, which lead us to then make that diagnosis of major depression.
Right.
Having made that diagnosis, one then has to institute treatment.
Right.
The treatment is on several different levels.
Correct.
The first level of treatment may be with, say, medication.
Correct.
The second level of treatment is to use the social support network
Right.
and to engage in therapy, where a person is able to better adjust to the changes in her life.
Right.
So those are the two levels at which you want to work first. When you talk about medications, then you have to think along the lines of treating the mother now with antidepressant medications. And when we talk about therapy, we talk about the adjusting to the environment where the mother's life has changed.
Right.
The mother now has the responsibility of the child, now has, more stress that is going to happen for her. But we should not forget that there are others that have to be taken into consideration. For example, now the father.
Correct.
The father also has the stress
Right.
of taking care of the child, of going to work, of taking care of the mother, to be of assistance and to be of support. And the father also needs some support as well.
Correct.
So
Right.
those are the things that we have to sort of look at
Right.
in the comprehensive treatment of postpartum depression.
Right. You really very well pointed out, because yes, mother is definitely going through so much changes, but people in close proximity do get affected by this change in the life, especially the dad, because he's also going through a lot of emotional uphill with the baby, with the extra financial stress to keep up with the expenses, and now the wife who needs more support. But he has his own needs as well, which needs to be taken care of.
Absolutely. There are many concerns. Some of the concerns most of the concerns have to do with the well-being of the mother as well as the child. Obviously, the parental instinct kicks in. But then there are other things, fitting in a schedule, a normal routine,
Right.
when you're not sleeping as well, when you're doing more work both at home as well as outside of the home environment.
Right.
And, again, sometimes while people have the benefit of extended support, like, mother-in-laws, or,
right.
the
Sister-in-laws,
grandparents
father,
are involved, or the extended family is involved, sometimes that is not there, and therefore, using friends or other support systems might be of benefit.
Correct. And that was my next question. Back home, we had like extended family staying together. So I think the stresses were a little bit different at that point, because like if you were tired, you didn't get a good night's sleep, somebody else would take care of the baby during the day, or there was a support system, somebody was cooking, bringing food. Now, since we have become more and more nuclear families or staying away from home, and we are in this different country with different stresses, so there's lots happening, I feel, in this country that puts a lot of pressure on new moms or to-be moms about keeping up with the looks, with the stress of losing the weight, the stress of keeping up with, the baby and all the demands.
Yes, that can be a potential stressor. But if we look at across the board, across all ethnic groups, there is not one ethnic group that is more susceptible to postpartum depression than, say, others. So across the board, the rates are all the same. There is no differentiating factor. So we have to be mindful of that, despite being in a different country, despite, the loss of the extended family or maybe lack of supports, that does not put, one ethnic group more at a disadvantage or than, say, other ethnic groups.
Right. So you're saying that it's, even though we are in a very stressful situation, most of us do tend to adopt and kind of make life a little bit at ease.
Adaptation is across the board a necessity, and we tend to do that.
Right.
So for the most part.
Right.
But then again, there is this big problem that is often unrecognized because there is a stigma that is associated to, say, a depression.
Correct.
See, depression is a subjective type of a condition where you don't feel it as you might feel, say, pain, or you can't see it as you might see in a swelling or things like that.
Correct.
So, very often the stigma of depression prevents people from seeking the help that they need. And it is not unusual for people to be very severely depressed or highly non-functional before they seek the help that they need.
Correct.
Now, this is of concern to us because antidepressant medications that we often use to treat postpartum depression usually take anywhere from 2 to 6 weeks
to take into effect,
to start working and helping the mother. And then you have to look and take into account the adjustment of the dose of the medication.
Correct.
So that it may be about 8 weeks before they may actually start feeling somewhat of a betterment.
Correct.
And therefore, one has to recognize this syndrome early. Postpartum depression usually occurs within the first 6 weeks of delivery. But it can extend as far as within the year of delivery. So if a person has given birth today, they can be depressed about 8 months down the road and yet have this postpartum depression. So one has to be vigilant. One has to seek early treatment, and one has to avoid getting into this whole perspective of stigma, because this is a treatable condition, and it is a fairly common problem. If I had the option, if somebody asked me a question, in a woman's life, if you had to pick one time when a woman is most likely going to feel depressed, then my answer would be in the postpartum state. Because the incidence and the prevalence of postpartum depression in women is most likely going to occur
in the postpartum area.
At that time, if at all they're going to have depression.
Right. So if we did it okay postpartum, hopefully we'll be okay as growing up.
That's true.
But as you pointed out about the stigma, a lot of times when I ask patients, and now we are required to ask once during pregnancy and once after the delivery, all this risk factors and stuff. And there are times people will contribute their moods and stuff to being tired, being lack of sleep. And as you said, we sometimes, even the close people in the family don't recognize till it has become to a very, very severe depression or suicidal ideations. And I tell the husbands, I tell the patient that don't just, say that it's just postpartum blues which have continued. If you feel anything, let's get you to the right person and let them just, at least you are in care of somebody.
Exactly.
And that specialized person can be able to start medication.
Seeking a consultation, seeking an opinion is not going to be harmful at all.
Correct.
But should you not seek treatment, then potentially there's always morbidity that is associated with it. There's unnecessary pain and suffering that occurs. And as you rightfully pointed out, this pain and suffering doesn't just extend to the mother, but it extends to the entire family because everybody is then affected. So seeking a consultation or an opinion is not going to be hurtful, but making the right diagnosis and knowing in advance that these things can be treated is certainly very helpful.
I think we can talk on and on. We're going to take a short break and we'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. Today we have Dr. Shah with us talking about postpartum depression and other postpartum psychiatric conditions. So far we've talked about depression, how it affects a lot of different ethnicity and different population, and there's no stigma should be attached to it because it's a fairly common condition and it's treatable, and if recognized early, we can avoid a lot of harm to the family, to the babies, and to the mother itself. So we've talked about postpartum depression, which is the common psychiatric illness we see in a postpartum. But there are other postpartum conditions like psychosis, anxiety, that can also... So how is that different than postpartum depression?
Right. So anxiety has a common neurotransmitter pathway, I might say that, in terms of its etiology. And therefore, depression very often is comorbid or associated with anxiety as well. Sometimes people are just worriers by nature, but sometimes what happens is that people become very particular about things and they start obsessing. And that is that they constantly think about a certain thing, whether it is fear that they might do something bad to the baby, whether it's fear that they might, not be able to provide for the baby. This fear can sometimes become so prevalent and so intense that the mother sometimes is not able to function because of this anxiety, this obsession, as we might call it. So obsessive compulsive disorder following delivery is also something that one should look out for.
Correct.
But while psychosis, which is a syndrome manifested by being commonly, the common term that is used for that is being out of touch with reality. What that really means is that a person experiences symptoms which are commonly things like hallucinations or fixed false beliefs like paranoid delusions, things like that, almost like sometimes thinking that people are talking about them and that somebody is going to hurt their babies, things like that. So while it is somewhat rare, the incidence is about 0.1 to 0.2%.
Compared to 10%.
Exactly. So, while it is lesser than, say, postpartum depression, it can be potentially a more tragic kind of a situation, because when that occurs, when psychosis occurs, the mother may not be able to control her behavior or be able to take charge or care of her baby at that point. And that is a condition that must be taken very, very, very seriously.
Now, are they like, apart from the postpartum period, when there are other, manic, psychotic people, are this women who've just given birth or during pregnancy, do they have that high functioning, like no sleep, extra energy? Is that somewhat different in postpartum period, or is
Okay,
it similar?
so what you're talking about is that very often people have a manic depressive type of a presentation as well.
Right.
And this frequently occurs in people who have pre-existing manic depressive illness, what is commonly referred to as bipolar disorder.
Right.
So people who have a history of bipolar disorder are more likely going to be at risk for postpartum depression.
Okay.
And when we start seeing, decompensation of that particular disorder, that is when a person goes into a manic phase, then that person might have excessive energy, not sleep a lot, wants to do a lot of things, and then becomes very impulsive. And as a consequence, may start doing things that may be somewhat inappropriate and may not necessarily be able to take care of the baby at that point. In fact, sometimes it even goes to the extent where a mother might require temporary hospitalization to control those symptoms. So manic symptoms following delivery and psychotic symptoms, which is having the hallucinations and the delusions and things like that, are two issues that should be taken very seriously, and immediate help should be taken for that.
And sometimes those patients might require hospitalization, not to harm themselves and to the loved ones.
Absolutely, absolutely. So, in those times, it is critical that people who are in the sphere of influence of the mother, that is the husband or the in-laws or the friends, the relatives, they should be quite vigilant about these symptoms, as should, of course, the obstetrician is the person who is going to see the mother postpartum fairly often. And so it is also important for the obstetrician to recognize these symptoms and to refer the patient to be able to get the appropriate treatment.
Correct. So bringing down now to the treatment of postpartum depression or psychosis, what are the medications that you usually give? And the commonly asked question is, how is it going to affect their breastfeeding?
Right.
So what's your advice on that?
So for purposes of pregnancy, all medications, whether they are psychotropic medications that we use, or for that matter any other medication, they're divided, as you very well know, into different categories.
Right.
So there are 5 different categories of medications. There's category A, which are the safest medications, and category X, which are
completely contraindicated.
Contraindicated medications. And in between, we have category B, C, and D.
Right.
So for purposes of our treatment, most of the medications that we use, which are antidepressant medications, are what we call as category C medications. Right. And with the exception of one medicine, which is Paxil or paroxetine, which is a category D as in David medication. So it has a lower category than the other antidepressants. Correct. These antidepressants we commonly use to treat both sometimes antepartum depression as well as postpartum depression. But when we take and treat these patients for depression itself, then we have to bear in mind that all of these medications can be secreted in very small amounts through the breast milk.
Correct.
And therefore, when a mother is breastfeeding the baby, we have to be mindful that there is a small amount of this medication that the baby is being exposed to.
Correct.
So generally the concentrations are not very high. And for the most part, the baby does not have any problems. Okay. But then there are some other medications that we sometimes have to be just aware of. For example, if a person is being treated with a mood stabilizing medication called lithium, and if the mother is suffering from bipolar disorder, and if lithium is being secreted through the breast milk, even though, as of right now, there is no contraindication for, a mother who is on lithium not to breastfeed, but it is possible that if the child is then subject to having this lithium, the child's kidneys are not developed, and the lithium requires excretion through the kidneys, and therefore there might be toxicity that might be built up. So we have to keep these kinds of things in mind.
So let your physician be your advocate and make sure what's right and what's not right.
Exactly. So we have to be aware that many medicines are secreted through the breast milk, and we have to also bear in mind that while the concentrations might be very small and they may not necessarily impact
have a
the
major
child,
impact, right?
there are other medications like
which might be safer choices.
Exactly, safer choices, and then there might be others which we have to be very careful of. For example, medications that are used for, say, cancers, which are cytotoxic medications, for example. We have to be careful about those kinds of medications, or medications that are being used, say, for terms of radiation and chemotherapy and things like that. So we have to always be aware that those medications may not be good
safe
for the baby or safe for the baby.
But also, when you're giving antidepressive medicine, it's such a, I commonly, when they come and ask, this other medication prescribed, what do you think? And I'm like, it's always risk and benefit. We always have to balance it. Yes, there's always slight risk to the patient as well as to the baby, but then the benefit outweighs the risk. And that's why the class C category is where we think that it's definitely going to be, even though there's a slight incidence of some animal studies showing some risk, but the benefit is too much, it outweighs those risks.
In any kind of treatment, the risk-benefit ratio has always to be considered.
Correct.
And, if you have a patient with postpartum depression, then obviously the benefit will outweigh the potential downside of it. The other part to that is that should we stop these medications before the baby is delivered? Because one of the things that we as psychiatrists are always mindful of is that there are withdrawal symptoms that the baby might have, because when delivery occurs, the circulation of the mother that is going through the baby now stops and the baby's own circulation takes over. So that if there are any medicine that the mother is taking before delivery, now that medication is not in the baby
anymore,
and therefore the baby may go through some withdrawal symptoms. And so, it's not an uncommon thing for us. If a patient is on antidepressant medication before they deliver, then we might sometimes go down on their doses of the medication to prevent withdrawal symptoms in the baby.
Correct.
And once delivery occurs, we may choose to go back up to therapeutic doses of the medications, so that now we've treated both aspects of it.
Correct.
And that's an important thing to keep in mind.
So to take home message, postpartum depression is a common condition. If anything we've done today is to bring it up, and please come up to your OBGYNs, your family physician, the psychiatrist, psychologist, or even when we do evaluation, please, and also the family, be aware what mother is going through, have some sympathy, and look out for the symptoms. So if we figure it out, it can be treated, and hopefully we don't have to hear it. It's really heartbreaking to pick up a newspaper and read about a mother killing their own kids, and hopefully we can reduce that as much as possible by rightful intervention. Till next time, good night.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.